So at the Kansas City Regional Hemophilia Treatment Center, we see all bleeding disorders. We see children from birth, and we see adults. We partner with our neighbor hospital, Truman Medical Center, to see the adults. The Children's Mercy Hospital sees our pediatric patients. We see patients with hemophilia A and B, but we also see rare bleeding disorders, von Willebrand disease, and platelet function disorders. We have a variety of programs, including a combined clinic with our adolescent gynecologist for young women with bleeding disorders so that we can allow for those patients to see both providers at the same time. We also have a launch program which assists in the transition of children from pediatric provider to adult providers, and this talks about some of the needs of adolescents as they get older. As part of our services, we provide our clinic visits at our two hospitals, but we also do outreach clinics to a variety of areas around both Kansas and Missouri, and we collaborate with regional physicians in the care of patients in case a patient needs to have a surgery at another hospital. We will collaborate with the surgeon or dentist or whoever's doing those things to ensure that patients have a good treatment plan to protect them from bleeding. At a comprehensive visit, the hemophilia patient will see a number of different team members. We try to be very organized and efficient, and the patient stays in the room after getting their height and weight and vitals done. The nurse will come in and ask questions about how the patient's been doing and take the medication history, recent history from what's been going on with the patient. And then they'll see the physician. They'll usually also see the nurse practitioner. They'll be visited by our data manager or any research projects they may want to participate in. They'll also be visited by our social worker and maybe our program manager. If they have specific needs, we'll have a physical therapist to see them. And then any lab draws that need to be done will be completed by the nursing staff, and then they're on their way. Typically, the longest time spent is with the nurse practitioner or the physician during that visit, and the time, while we try to be efficient, we allow as much time as the patient needs. So a patient typically spends anywhere from an hour to a few hours in the clinic, depending on their needs. So when patients need to have certain procedures done, the first issue we encounter is making sure that that person is comfortable with a patient with a bleeding disorder. And that can be variable. Many dentists in particular are not comfortable caring for patients with bleeding disorders. So finding someone who will take on that patient is one of the first things we have to do. And sometimes that involves communication with that provider to say, we're going to take care of the bleeding disorder. You do what you need to do. And we're going to have a good plan in place for you. For patients who need a surgery at another center, our nurse practitioners are incredibly effective in getting that plan in place. So they'll communicate with the surgeon, whoever's doing the procedure, and ask what the anticipated risk is, and then in collaboration with the physicians, we'll come up with a treatment plan. We'll communicate that treatment plan to the surgeon. It may involve the patient taking medication the day prior or prior to the procedure. They may need to come to our clinic to get that, and then they would proceed to getting the surgery done. We'll also communicate with their home health care company on if they need treatment after the procedure to make sure that all that's in place. This usually is done a couple of weeks before the procedure so that we have all of the information in place so that the patient can safely undergo whatever they need. The Kansas City Hemophilia Treatment Center actually supports patients across all of Kansas, Colorado. We take care of patients all the way down to Oklahoma, all the way up to Nebraska, down to Arkansas. We cover half of Missouri. So we have a pretty large catchment area of patients. So instead of making all those patients come to us, we go to them, and we have outreach clinics a couple times a year in Wichita, Kansas. We actually go out to Dodge, Kansas, which is about a 6 to 8 hour drive away from Kansas City. We have outreach clinics in Joplin, Missouri, and Springfield, Missouri as well. We do about a third of our comprehensive visits in outreach, and so not only is it important for us to take that care to the patients in these outreach locations, but it also, I don't know if our clinic could actually take the volume of seeing all the patients that we see in outreach. Those outreach visits can last anywhere from a day to a week. When we go out to Dodge and then Wichita, our nurses are out of the hospital out doing outreach clinics for a week because we try to do those back to back. We also use telehealth, wherein our social worker will communicate with families through telemedicine, and we're able to use the Children's Mercy facilities in Joplin and Wichita to facilitate these visits. We have a really great relationship with the Midwest Hemophilia Association. Every year we present at the Family Fun Fair to provide education to patients about a variety of things that are of interest to them. This year I'll be presenting on the really new drugs that are coming out in hemophilia, including gene therapy. Other ways we interact is we staff the Midwest Hemophilia Association, the medical tent for camp, so that they have a camp every year for children with bleeding disorders, and our team is the medical team for that camp. We also, as I mentioned, work closely with the gynecologists. We have a large oncology population here and a large oncology group that part of our division that we work with them, and we see patients in the hospital who have bleeding disorders and support their needs. There are a lot of providers that may not know a lot about bleeding disorders, so we communicate with emergency room doctors across the region and educate them. We often will do educational talks both for patients and families, and then sometimes also for other providers on bleeding disorders. I did one a few years back for a local gynecologist on von Willebrand disease. I also did a similar one for our adolescent medicine physicians. We also educate the residents and fellows regarding bleeding disorders, which is, of course, part of our job. We have a robust coagulation consult service that they are able to learn about bleeding disorders when they rotate on that service. We also have a collaboration with our Survive and Thrive, which is the long-term survivors of cancer. We collaborate with them on the LAUNCH program, which is that transition program I mentioned earlier. When we go to outreach clinic, we also provide, very commonly, particularly if it's a multi-day outreach clinic, we'll do an educational talk while we're there for the families that are in that outreach location. So issues with billing insurers arise from a number of different things. One is that the phone call time that is spent by our nurse practitioners, ranging for surgeries and such, is difficult to reimburse, and it isn't reimbursed particularly well. And so the time spent trying to get that reimbursement isn't really rational once you actually get the reimbursement. It doesn't really pay off. They also do a vast amount of pre-authorization for families that is not really billable as well. So insurers oftentimes require extensive pre-authorization before providing necessary medications for patients with bleeding disorders. And so an immense amount of time is spent on phone calls by our nurse practitioners and nurses to get pre-authorization, arrange surgery, discuss care with other providers, and provide prescriptions and such to home care companies. Our social worker, her outreach to families, her assessments, her time on telehealth, but also her time arranging transportation or lodging for families, helping families navigate some of the financial difficulties that arise because of these very expensive diseases. That time is not really billed for or accounted for in the current structure of billable hours. So there's a lot of time that is spent in the care and coordination of care of patients with bleeding disorders that is really not reimbursed. We are the ones, of course, who know the patients the best, and so we are able to know what the needs are, and we're able to identify the best dose for patients. We are usually within a very narrow margin in terms of dispense versus prescribed factor dose. And our reason for that is that we are able to anticipate what assays will be needed in our patient population. We're able to manage our inventory so that we don't have files sitting on the shelf that we want to get rid of. And we also have that close patient relationship wherein we can adjust our dosing appropriately for that patient. So we find that when we compare what our factor program provides to patients and others, we are much closer to the prescribed dose than other entities are. And I think it really has to do with that patient relationship that allows us to just have a better knowledge of what the patients need. And that, of course, is important in making sure that we are being good stewards of the financial needs of the patient and their insurers.